So the topic given to me is stem cell solutions for chronic sequelae of ocular burns. Now, whenever we're talking about the damage caused by chemical injury, it is by one of these 5 mechanisms. One is that you have decreased tear production or delivery because of damage to the accessory lacrimal glands or their ductules, or the ductules of the main lacrimal gland. You have inflammation of the ocular surface, prolonged inflammation, which can cause damage by itself. You have conjunctivalization of the surface, which is really the main thing which happens in stem cell deficiency, which affects the vision because the conjunctiva grows onto the cornea. And you have, because of the loss of the stem cells, you don't have regeneration of corneal epitheliums, you have breakdowns, etc., secondary to that. And finally, you've got mechanical injury because of the lid abnormalities, lashes getting inturned, keratinization of the lid margins. So you have friction with the corneal epithelium, which can cause problems. And of course, recurrent epithelial breakdowns can result in stromal melts, which can cause a lot of problems. So when we talk about limbal stem cell deficiency because of chemical injuries, it can be unilateral or bilateral. It can be partial or complete, and it can be a dry and wet, and it can be several combinations of these. So this is a pictorial representation of a moist versus a dry limbal stem cell deficiency. Now in the picture on the left, you have the entire cornea is conjunctivalized, you've got symlephra, but there are tears. Okay, so this kind of eye is one that will respond to stem cell therapies, which is what I'm going to be covering. The eye on the right is a dry, absolutely bone dry eye, along with, of course, stem cell deficiency and this keratinization of the surface. So this eye, stem cell solutions are of no use. You have to do something else like a keratoprosthesis. So we all know that the stem cell resides in the basal epithelium of the palisades of Vogt, and they go through several stages: transient amplifying cells, post-mitotic cells, and terminal differentiated cells before becoming the final epithelium. And they go from the periphery to the center by means of the XYZ hypothesis, which we all know about. Now, where can one get stem cells when we want to do a transplant? Okay, you can get it from the same eye, which is called an ipsilateral autograft. You can get it from the fellow eye, which is a contralateral autograft. You can take it from a live-related donor, which is called a live-related allograft. You can get it from a cadaveric donor, which is a cadaveric allograft. Or if you don't have an eye source, then you can take it from the oral mucosa, and that is not exactly ocular stem cells, but you have oral mucosal stem cells, which then transdifferentiate into the ocular surface epithelium, which is called a cultivated oral mucosal epithelial transplantation, or COMET. Same thing, which is shown in this slide as well, so well on it. So one entity is bilateral limbal stem cell deficiency, like is shown in this picture. There's a partial limbal stem cell deficiency in both eyes. So one could, if there is a source in the same eye, you could take an ipsilateral limbus from the same eye. But if it is completely involving, then you have to go to a live-related allograft, or a cadaveric keratolimbal allograft, or a COMET, which is from the mouth. And now we have the option of doing a cadaveric or a live-related SLET, which I think has really eliminated the other options to a large extent. And if it is a bilateral partial this thing, then you could take stem cells from the same eye, cultivated them in the lab so that you have enough amount of epithelial cells, and then transplant it back onto the same eye, which is called an ipsilateral cleft. So if you have a unilateral involvement and the other eye is pretty healthy, then basically you take the source of your stem cells is the fellow eye. You can either directly do a conjunctival limbal autograft, or you can take stem cells, grow them in the lab, and then put them into the fellow eye, which is called a CLET, cultivated limbal epithelial transplantation. Or you can do a SLET, which is the popular technique nowadays, in which you just take stem cells from the fellow eye, limbal palisades, and then put them all over the eye, as was shown in the previous presentation by Sumana. So we've already covered amniotic membrane graft. I won't go into this. Before we had these stem cell options, we used to do cultivated conjunctival limbal autografts or allografts. So basically, you take 2 or 3 cloacas from the superior and inferior opposite limbus, conjunctiva and the limbal epithelium. And then you, and after harvesting this, you go to the donor eye, remove the entire fibrovascular pannus, and then you just suture these conjunctival limbal grafts on the opposite sides. And from here, you would have the epithelial cells growing out and covering the, populating the entire eye. So this works very well actually. But only problem is from the donor eye, you're removing a lot of limbal epithelium, almost 4 to 6 cloacas, which can sometimes cause a problem. Okay. You can induce a limbal deficiency in the fellow eye, especially if they have some other event after that. So we covered all these things. I'll just show a few videos. So cultivated limbal epithelial transplantation was in vogue before we had SLET. Now, I think largely most people are not doing it. Anyway, this was something which only the institutions could do because you should have a lab where you can culture stem cells. So I'll just show one example of one of my patients. This was a 6-year-old boy who I managed when I was in LV Prasad. So had a Lyme injury. You can see total limbal stem cell deficiency in the left eye, along with a small patch of keratinization. But by and large, the eye was dry. And the other eye was completely healthy with intact limbal palisades. So we took a biopsy from the right eye, grew them in the lab, and then after 2 weeks, we did a clet in left eye. So this is how you do it. You take the limbal epithelium like so. We take a little strip of 2 to 3 cloacas, then transport it to the lab. In the lab, it is broken down into small bits over a slide, and then it is grown to form a monolayer of confluent limbal epithelial cells, which look like this, which grow out from the explants. And once that is ready, then you go take the patient back for surgery. So this is the eye so badly fibrosed that we couldn't put a speculum initially. So essentially, you're excising the entire fibrovascular pannus. Once you have released the semblifera, you can put in a speculum, and then basically you have to peel the whole thing off at the right plane, leaving behind no fibrovascular tissue stuck on the ocular surface. So you have to get a bare sclera and cornea, like so. So in this particular case, we noted that there was a lot of thinning in the cornea, and the underlying cornea was quite scarred. Now, this was a 6-year-old boy. I wanted to visually rehabilitate him as fast as possible. So in this case, we decided to also do a deep lamellar keratoplasty. I just did a lamellar manual DALC in this particular case because it was a large limbus to limbus graft and I didn't want a perforation. So as you can see, we've done that. And after the cornea was sutured in place, we removed the epithelium, then we put glue and put these little, we put the amniotic membrane graft, which had the monolayer of cultivated limbal epithelial cells on top, and spread it out on the ocular surface like so. So you can see over time, the eye, which was like this, became very clear, and the patient actually managed to come out and get good vision, and we managed to avoid the patient from getting significant amblyopia. SLET is the new kid on the block, in which basically you are taking a small explant of a small biopsy from the healthy eye. In this case, we are taking a very big biopsy, but usually 1 to 2 cloacas are enough. And then you basically go to the unhealthy eye, remove the entire pannus like was shown in the other eye, in the other video. And then you take this limbal tissue and break it into small bits. In this case, we're doing it on a Teflon block, but you can also place it on the ocular surface and cut it with a scissor. And each of these bits is called an explant. So you spread it out all over the cornea, peripheral cornea. Avoid putting it right into the center because those explants can then affect your vision. And then you stick them down with fibrin glue. Once the glue has coagulated, then you can just put a bandage contact lens. So and these patients again do very beautifully and get excellent results. So this is just to show when we don't have a source of SLET in the fellow eye, then nowadays we can do cadaveric Allo-SLET. This was covered by Sumana. So I'll just quickly run through this. So again, because you have the whole cadaveric tissue, you have a lot of limbal tissue, so you can take lots of it. This particular case, because the fellow eye also didn't have a source, we did a cadaveric the cadaveric SLET. What I found is, unlike live related and cadaveric conjunctival limbal grafts or other limbal transplants where you need to do systemic immunosuppression, in cadaveric allo-SLETs you can probably get away with topical immunosuppression and tacrolimus, and I managed to manage a few patients without giving systemic immunosuppression, and the grafts have managed to survive for a very long time. So this particular case, you can see from this, we came to the image on the right and got a very good outcome. And this is on the OCT, the explants and the epithelium which has grown out healthily from them. So this was another patient who had a bilateral partial limbal stem cell deficiency. And as you can see, we have done a ipsilateral SLET. So from the same eye, we have taken some limbal tissue and then kind of transplanted it back onto the rest of the same eye, and we got a good outcome. I'll just end with this little case, a 75-year-old patient who had presented to my clinic after 2 months of cataract surgery and severe decreased vision, redness, watering in both eyes since 2 weeks. Patient was on steroids, antibiotics, and was very, very uncomfortable with intense burning after instilling drops. Immediately after instilling drops, patient complained of burning, and the drops were being instilled by the daughter-in-law. So this is what. Can I just take a couple of minutes more, Aditi? Yes. So this was the picture. You can see the right eye had this large epithelial defect on the cornea, and the whole surface was quite inflamed. And left eye again had a large PED, and there was diffuse conjunctival congestion with edema, etc. And there was a lot of SPKs in the remaining cornea, and there were significant pigments in the endothelium. So my diagnosis was possible diagnosis was a chemical injury, a Munchausen syndrome by proxy, which means that somebody was contaminating her eye drops, and that's how she was getting this. Or there was a drop, some sort of a drug toxicity. The drop itself was not proper, or maybe a neurotrophic keratopathy with some sort of a mucus fishing syndrome. I forgot to mention the patient also had an inferior conjunctival epithelial defect. So we stopped all drops, just kept preservative-free lubricants, and the right eye epithelial defect started contracting, but the left eye remained the same. So we did temporary tarsorrhaphy, and you can see the right eye is much better, and left has a tarsorrhaphy in situ. So right eye, that epithelial defect didn't completely heal, so we put a BCL, and left eye we added an amniotic membrane graft. The right eye healed completely, the BCL is removed. Left eye, the amniotic membrane got integrated like this, and this is how it was. Right eye was quite good, clearing well, but left eye developed a scar with pannus. By day 75, the right eye was again clearing a little bit, but left eye developed this kind of a severe pannus with a PED. So we repeated AMG and tarsorrhaphy. And again, so right eye was continuing to clear, left eye, the AMG got integrated with vascularization and was doing well. So this day 150, right eye cleared to about 2050, and left eye was severely edematous, along with total scarring and not scarring, but more of a superficial scarring with total limbal stem cell deficiency with tarsorrhaphy in situ. So we decided to do a SLET with a DSEC for the left eye because there was endothelial dysfunction as well. And my theory was the epithelium will not take if the endothelium is not healthy, because the epithelium will always be edematous. So we just did a, I mean, I won't go into the details. We basically did a DSEC like we routinely do, and took limbal biopsy from the fellow eye, dissected off the pannus, and put the explants on this eye. As you can see the DC tissue underneath. And you can see that this patient then eventually did quite well. By day 200, this was the picture, and by day 240, and finally by 1 year, the eye became fairly good, the cornea became compact, and the surface was fairly healthy. So that's about it. Just try to give you an overview of all the stem cell options for sequelae of